Just pretend we're the space shuttle.
Okay.
Let's do this. Welcome.
All right. Welcome, everybody. Healthcare for All and partners are really delighted that you're here with us this evening. This meeting is being recorded and it will be archived on hc4us.org, our website. Tonight, we are reviewing the contents of Calcare, the California Guaranteed Health Care Act, which was introduced February 7th, 2024, and was authored by Assembly Member Ash Kalra and several co-authors. So we encourage everyone to read the full Calcare text, which is on our website. But tonight, to help you along that mission, our team of 10 Calcare advocates is going to give a very brief overview of what is in the actual text of Calcare AB 2200, which is now on its way through the assembly committees. So after each 3 segments presented by our team, we will take a couple of questions from you about those 3 segments in the bill text. We are not doing an analysis or a discussion or a deep dive of the bill tonight, but we will in future meetings. But we will stay online after adjournment from 8:30 to 9 for any additional questions. Our partners at API for Calcare are hosting a Calcare deep dive reading and discussion group on a weekly basis. So to join them, send an email to api4forcalcare@gmail.com with AB 2200 reading group in the subject line. So tonight's Facebook questions can be typed in. Zoom questions can be entered into the chat or asked verbally with a hand raise. And if you're using a phone, you can dial *6 to unmute and mute and *9 to raise your hand. Please be brief and to the point. As time is an issue, we will only be taking a couple of questions live. Feel free to contact us with additional questions at info@hc4us.org. So we will start now with an overview of the bill. The very first pages of Calcare AB 2200 text are the Legislative Council's digest brief summary of the changes that the proposed bill will make to current law. The digest describes existing federal and state laws and identifies state administrative and regulatory jurisdictions. It also identifies provisions of the bill such as comprehensive universal health coverage, cost control, benefits, the incorporation of federal and state programs, enrollment, and implementation specifics. The digest reviews the waiver approval, the state fund, staffing, price negotiations, creation of a drug formulary, and the fiscal analysis necessary for implementation. The Calcare Board of Governance, 5 advisory committees, and an Office of Health Equity are defined along with the involvement of existing state agencies for regulatory and administrative support. A schedule for reporting and a system for public input and responsivity to necessary adjustments is codified in this bill. So the rules for provider participation, the responsibilities and prohibitions, contracts, rates, payments, and institutional budgets are also described. The mandate for a revenue plan to fund the Calcare Trust Fund is also established. After 20 years of volunteering for single payer in California, I am especially excited about this bill because it is a true single payer bill, finally removing the Wall Street profiteers. It eliminates insurance and extractive intermediaries. The only goal is a healthy population supported by a robust, publicly funded and directed system. Calcare spends all of our healthcare dollars on the actual delivery of our healthcare. A novel arrangement, folks. We have never had this. Responsivity is guaranteed by deep public inclusion in governance, mandated transparency, public input, data collection, routine reporting, and accountability to us. Calcare is monitored for performance to determine what needs to be improved. The flexibility to affect changes, to meet needs as they arrive, and the opportunity for public input are really transformative. I have never seen a bill that includes us all in the process of maintaining our health system for all. AB 2200 is truly a democratic bill for the people, of the people, and by the people. It is very exciting. We are going to slog through those sections of it, but I think you will see that it's really something brand new and very exciting. So thanks to Carmen Comsty and staff and the entire leadership of California Nurses Association for this life-saving, revenue-generating, job-creating, community revitalizing legislation. Calcare will transform our sickness system of harm into a model of gold standard healthcare benefiting us all equally. So let's review AB 2200 now, starting with Gina Viola.
Good evening, folks. My name is Gina. I use she, her pronouns, and thank you for that, Maureen. The digest is the summary of the bill. And we know that most of the legislators probably don't go beyond that summary. And let's only hope that they give it as deep a dive as Maureen just gave us, because that's probably a lot more than some of these legislators know already. So Section 1, we're getting into the nitty-gritty of what the bill declares. So things are stated and defined for us in these sections, like Obamacare, which is technically called PPACA. It didn't cover everyone as we would have hoped, right? This is called out in the bill for us. Moving further down, things are defined, like the fact that individuals, employers, and taxpayers have had unending rising premiums with reduced choices in coverage. So these are things called out in the bill. So right at the very front, we're talking about why we need this bill. Calls out wasted billions on administrative costs in our current system, right? And also talks about the intent of the legislator to establish a single payer system with guaranteed health care for all. Also included in Section 1 is language about the federal waivers. You'll hear a lot about that. That will be obtained to funnel federal tax dollars into our state-based system, creating a Calcare trust fund. We'll be hearing more about that. And, I just want to read B1. It is further the intent of the legislator to establish the California Guaranteed Health Care for All program to provide universal health care coverage for every Californian, funded by broad-based revenue. So it's important for folks to know that, and that is, expressly stated here in this section. Also talks about how existing state programs like Medi-Cal and Medicare will be replaced and merged into Calcare, which will operate as a true single payer system. These are questions that come up quite a bit. The intent, again, we're talking about intent, is to provide greater benefits than current existing health plans currently do. And it does away with healthcare being an employment benefit. The section also calls out that Calcare will not change the way standards of care are regulated. That would mean that what remains is the Secretary of California Health and Human Services still has some regulatory say over the actual healthcare part of things. Moving down on Section 1, F-1, if you're interested, talks about confidentiality. It's stated here that Calcare will not share any data about patients with law enforcement or immigration. And it further states that law enforcement cannot utilize Calcare funds to investigate or enforce any of its ongoing activities. And I think that we can understand why this needs to be called out pretty specifically, because it's no surprise to anyone that law enforcement tends to get its hands on so many different government budget line items. So I was very pleased to read this in this part of the bill. And then also calling out the cost measures for prescription drugs, right? Addressing the high cost of prescription drugs as part of this section as well. So it's really hard for me to do Section 1 justice, so read it yourself, but that's like an overview. And I picked out things that I seem to be getting questions on mostly from folks, so hopefully that's helpful. Section 2 is, again, just defining things for us, right? What's in a name? Chapter 1 and Section 2, it tells us the name. The name is the California Guaranteed Health Care for All Act. We call it Calcare, so you can use both of those terms. It also talks about the governance of Calcare, and it's going to be governed by a Calcare board. And later on in the bill, it will just refer to board, and you're to know that that's the Calcare board.
Thank you so much, Gina. We have to move on. I know there's so much
Sorry,
more. So
sorry.
people read the bill. Our next
Pages
presenter,
5 through 8, definitions.
thank you so much. Next is Tim Horner. Hi, Tim.
Hi. Are we?
Are you, sorry, we're in the same place. Do you have
I'm not. Are you muted?
your,
Is Tim
I'm
here?
hearing from the great beyond.
If you're echoing, you may have two devices, so.
Oh,
turn-
you have to unmute. You have to unmute, Tim. There you go.
Okay. Here we go. Are we good? Okay, sorry about that. Yes, my name is Tim, and I am covering the governance of the bill is where my section begins. We've already heard a little bit about it. It starts with an explanation of the Calcare board. So the Calcare board is going to be the executive board that's responsible for implementing, establishing, administrating Calcare for the state. It's going to be made up of 9 voting members, 5 appointed by the governor, 2 appointed by the Senate Committee on Rules, and 2 appointed by the Speaker of the Assembly. And they're very specific about who can make up this board. They want a diverse diverse expertises on the board. There's going to be 2 healthcare professionals, one of which currently practicing healthcare, 1 registered nurse, 1 public health professional, 1 mental health professional, a representative from a labor organization. They go on specific roles that each member of the board needs to fulfill to show that the board is being the bill is being administered and planned and executed by people that have lived experience either providing care or needing the care that Calcare will be providing. It also goes into the ethical safeguards about compensation and what kind of gifts need to be reported. And it says that all the board meetings will be open to the public. Now, the board will be establishing a few other committees. The first that they talk about is the Calcare Public Policy Advisory Committee. Now, this committee will be advising the Calcare board on all policy issues for Calcare. Again, they specify specifically who's going to make up this committee: 4 healthcare professionals, 1 registered nurse, a representative of a licensed health facility, a behavioral health provider, a dentist. Again, populating this committee with people with lived experience providing or needing the healthcare that will be provided by Calcare. The board will also be appointing an executive director whose job it will be to basically establish and implement Calcare. They will be hiring the necessary staff to administer Calcare, and they'll give preference in hiring to individuals who are displaced or unemployed by the implementation of Calcare. So they'll be determining the goals and priorities for Calcare. The staff will be developing the budget and reviewing it annually. They'll be establishing the enrollment system and the timeline for when that can happen. They'll also be establishing a website that will give all the information to the public about Calcare that the public can go to for anything that they need. They will also be providing support, training, job placement for people who lose their jobs because of Calcare. And they'll be providing an annual report to the governor and to the legislature and posting that report on the website for great transparency for everybody. The last committee that they talk about in my section is the Advisory Commission on Long-Term Services and Support. So there'll be a specific committee advising the Calcare board specifically on just long-term services. Again, it'll have 11 members. 2 of them will be people with disabilities that need long-term services. 2 of them will be senior adults who use long-term services. 2 of them will be providers of long-term care. One should be a family attendant or a caregiver. One will be a representative of a labor organization representing the workers who provide long-term services. Again, all things will be open to the public, and there's more in there that you can read. It's pretty straightforward, but it's great.
Thank you, Tim, so much for that report on the governance. And now we have Alex. Hi, Alex. Unmute.
Hello. Okay, so my section picks up where Tim left off, and it starts with just transition. So the funds are allocated to the Secretary of Labor and Workforce Development for folks who are employed in the current system for job training and retraining, job placement, and preferential hiring. The Calcare board will also establish an advisory committee on public employees' retirement systems. Half of those representatives at least must be from public sector labor orgs. One of the things this committee does is provide recommendations regarding federal approvals that support the transition of Medicare plans to Calcare for public employees in the current system. With the committees in both Tim's sections and mine, the people who are affected by the shift are the ones who lead on that aspect of the shift. This is significant because it brings lived experience to the transition and also creates a buy-in for people at all levels. The next section to me is about transparency and data collections. So significant data is collected prior to implementation and is also collected on an ongoing basis. This data informs cost allocations for care as well as global budgets. An example of a global budget is a hospital. So let's say Cedars Hospital would apply for a global budget. In order to get it, Cedars must submit their annual financial data, broken down by care unit and department, including dollar value at cost of charity care, the number of registered nurses per bed by care unit, and a description in dollar value of all information technology, including AI. This data is the equivalent of financial lab work, and it will tell us how their financial cholesterol is. Is there enough oxygen in their financial blood cells? How strong are their financial bones? This section says, before we make global budgets, let's see your current budget. Additionally, data collected in this section will be made publicly available and searchable via one website. So the summary here is transparency. We'll know how it's currently going and how Calcare impacts it. The Calcare board will create a contracting manual that will be substantially similar to those in the state contracting manual. Consistently through the sections of the bill that Tim and I covered, they don't reinvent the wheel. If there are existing groups, entities, or systems in place that accomplish what's needed, those are incorporated. Where new info is necessary, there are provisions for that. The next one, as Gina spoke to, protections from law enforcement, and this has to do with equity. It's section 100619. It protects undocumented folks in hyper-policed communities. It states that Calcare info, facilities, property, equipment, and personnel cannot be used by law enforcement to investigate or enforce criminal or civil violations. My only note is that the language here includes notwithstanding any other law, which is a flag to me that we need to keep an eye out for new legislation that may be introduced after Calcare passes. Fiscal responsibility, my favorite. After Calcare is passed, but before implementation, the board will deliver a fiscal analysis to determine if Calcare can be implemented and if revenue is more likely than not to cover program costs within 8 years. The analysis goes to the chairs of the committees on both health and appropriations in both the Senate and Assembly. Data collected prior to implementation will be used to inform and confirm the fiscal analysis. The current projection is that California will save 10% of current health expenditures by providing coverage to every resident under Calcare and eliminating the waste and dysfunction of the current for-profit system. And my last section is eligibility and enrollment. Every resident of California is eligible for Calcare. Everyone, are you a resident of California? Yes, you get Calcare. There's also a provision for colleges, universities, et cetera, to purchase coverage for students and their children and dependents, and a process established to automatically enroll children at birth, which means the next generation of Californians will start life with full medical coverage.
Thank you, Alex. Really appreciate it. All good news. So, Gina and Dennis, are there any questions, or Scott, any questions? Facebook or any other place about these sections? Okay, we're going to have plenty of questions at the end of the hour as well. So
no questions on Facebook, so.
no questions right now. So then we will continue. So Alice Mopin. Hi, Alice. Oh, Alice, unmute.
And I was saying, hi, Maureen, and thank you so much for bringing us all together to deliver this important information. I was thinking that I was also going to do eligibility and enrollment, and Alex brought up some very important points, and I concentrated on a couple of other things that in addition to covering every resident of California, and they will all be eligible, is that there will be no enrollment fees required at all. Members will not pay premiums, co-payments, or any other form of cost sharing for Calcare covered benefits. Members will be able to choose any participating doctor that they wish, which is big. And I think I might be repeating something that Alex said, but I liked this one, is that members will be automatically enrolled at birth. So I think, yes, that is the way to go to keep it going. And then I'm going to move into the benefits section. So the determination of medical necessity will be made by the patient's doctor. And this is, I've been a Kaiser member for years, and this is something that I really like about Kaiser, is that once the doctor says, you need this, that's it, you got it. And I think that that is a game changer and a wonderful one. Covered services will be comprehensive and will include prescription drugs. The range of services, and I think all of us by now have heard about Medicare for All, and you might get the idea that, oh, it's going to be just the same as Medicare, but that is not so. It will be an expanded Medicare with things that Medicare has never had. So for example, dental, vision, and surprisingly and wonderfully long-term care, which has really the having to struggle at the end of one's life in order to be comfortable and healthy has been very difficult for millions of people. So I'm so glad that that's in there. And then Maureen, that you specifically asked me, you had some questions about this section about how the board deals with denial of healthcare items or services by a participating doctor. And the way the sentence is written, it says the board shall establish a process where individuals may bring a disputed healthcare item or service or a coverage decision for review to the independent medical review system. And that section, it differentiates between a healthcare item or service, in that relates to the practice of medicine. And an example would be an early discharge by an institutional provider. And then a coverage decision means the approval or denial of healthcare items or services by a participating doctor. And that's all I got.
Thank you so much, Alice. Next we have Chang Sim Lim. Chang Sim.
Hi. So I'm going to do chapter 5, which is delivery of care. And the chapter is divided into 2 articles. Article 1 is healthcare providers. So to qualify to be a healthcare provider under Calcare, a provider must be physically located and licensed to practice in California. They must also sign up to participate with the Calcare board. And patients will be able to select their primary care provider. No referral is needed from the primary care provider to see another doctor in the Calcare system. Then the Calcare board will establish procedures and standards for recognizing out-of-state providers to provide care to California residents who need care while they're temporarily out of state. And providers must agree to the following terms to participate in Calcare. They cannot discriminate in providing care. They cannot charge patients for anything that's covered by Calcare. And this is upholding the Calcare principle of no out-of-pocket costs at the point of service. Providers will also need to provide required documentation to the Calcare board. They cannot use cost calculation formulas and coding software that are proprietary. This means providers cannot use non-transparent means to determine how much they should be paid. And providers are also prohibited from using coding to produce desired outcomes, such as higher payment for themselves. So no one affiliated with a provider group can receive kickbacks from whomever they do business with. So no bribery is allowed. And most importantly, providers cannot enter into any kind of risk-bearing agreement with any entity outside of Calcare. In other words, no ACOs under Calcare. And then it is illegal under Calcare to punish or fire an employee for whistleblowing. Calcare providers cannot bill Calcare members for a benefit that Calcare covers, but they can bill Calcare members for a non-covered benefit. Calcare members can opt to receive care that is a Calcare covered benefit from a non-Calcare provider. And in that case, the Calcare member will have to pay for the care themselves. So now we're into Article 2, which is about the payment system. Using global budgeting, Calcare will make quarterly lump sum payments to institutional providers such as hospitals and nursing homes to cover their operating expenses. And group practices and county health services can choose to be paid on a fee-for-service or salary basis. And they can also elect, with the approval of the Calcare board, whether to be paid using time-based rates for certain types of care. Individual providers, however, are to be paid on a fee-for-service basis. The Calcare board can allocate special projects funding. The board can allocate special projects funding to staffing as well as construction and improvement of facilities in medically underserved areas and to address healthcare disparities. And the global budgets are to be negotiated annually by Calcare and institutional providers with quarterly reviews to determine performance and need for adjustments. And medically underserved areas may receive higher global budget payments along with higher individual provider payments. Providers cannot pocket revenue generated by outsourcing care covered by Calcare to a cheaper third party. So this effectively prohibits outsourcing for profit. And Calcare rates will be based on Medicare rates and will be updated annually. The Calcare board will adopt regulations to pay capital expenditures to nonprofit or public health facilities with priority for medically underserved areas and to address health disparities. Capital expenditure funding will not be provided for capital projects that divert non-Calcare funds from patient care or staffing. And providers can retain margins or unused global budget funds to meet Calcare member needs. However, margins due to limiting access and quality of care cannot be retained.
Thank you so much, Chang Sim. I especially love the part about no bribery. Too bad we don't have that for the politicians.
It's really important.
Oh, okay, go ahead.
Calcare board, in consultation with relevant state agencies, will negotiate bulk pricing for pharmaceuticals, medical supplies, technology, and also establish a drug formulary and regulations for all formulary medications.
Thank you so much. Everyone is really condensing. Thank you. And James Sorrentinos.
Okay, there's a little bit of doubling up here, so I'll try and skim over that really quickly. So we're looking at the establishment of annual global budgets for operating costs only. So operating is not capital expenses and it's not special projects. So operating costs are anything directly involved in the delivery of healthcare, which is drugs, devices, tests, protective equipment for staff, anything to make a hospital run. the way these budgets are constructed is the Calcare board's going to be looking at a hospital or service provider's expenses over the 3 years prior, basically the types and the numbers of services given, and the rates, as Cheng Sim mentioned, will be initially based on Medicare and adjusted annually. Now, if there's a critical incident with a provider, these budgets can be adjusted quarterly. Things like adjustments in volumes, capacity, and there's also going to be cost comparisons. If you suddenly decide my costs have risen by 20%, you need to prove it by comparable hospitals in your area. There will be a preference for additional budget in underserved, underrepresented areas to rectify those health disparities. And you can actually apply for that. If a service provider doesn't agree with the board's decision, there is an appeal process. There will be an administrative judge who will listen to those cases. They talked about margins. So it's a term, a surplus. It's a term we use that's not profit. But in terms of any healthy organisation, there needs to be a buffer. If something happens, you can't just be. It's not like the old government departments. You're given $1 billion a year. You need to spend it all, otherwise it gets taken back. You are allowed to keep that. And there's also the formulary, which is basically the pharmaceuticals, the pricing, and as Cheng Sim mentioned, that's going to be done at, I guess, a more centralised level. That's really all I needed to say. Thank you very much.
Thank you, James. Now we can pause for a couple of minutes for any questions. Does anybody have any questions? Gina, Scott, Dennis, any questions that you can see?
No.
None for me.
Oh, wait, Lynn. I see Lynn.
Hi.
Lynn, unmute.
I just did.
Okay.
Can you hear me?
Yeah, what's your question?
Okay. If somebody mentioned these, my apologies. I started to read the bill, and the section that I saw was how many different healthcare providers in the state. I mean, all these various clinics, which will cover everybody, which is great. What about if you get sick outside California, does Calcare pay for that?
The answer is yes, they do. That was in one of the sections. Who had that section? Do we have that one already?
I addressed that.
Yes.
So basically, Lynn, the Calcare board is going to establish procedures and standards for recognizing outer state providers that will be able to provide care to California residents who need that care while they're temporarily out of the state. So we will know. I mean, I don't know what list they will, base it on. But if they're basing rates on Medicare rates, then I would imagine that they could very easily base that list of out-of-state providers on the Medicare, on providers who take Medicare. That's a guess on my side, but there will be a procedure set up to have a directory essentially of out-of-state providers who can provide care and that Calcare would cover.
Thanks. I have one quick thing, because we're getting federal funding, and right now doctors taking Medicaid and Medicare aren't being paid very well. How do they see the MD salaries under Calcare?
Who had that section? That was providers. Cheng Sim again, right?
Yeah, they said that the text of the bill says that the rates would be based on Medicare, but as a starting point, it didn't say that it had to be exactly Medicare. So there's room for adjustment.
Yeah, because that's not, a lot of doctors don't take either Medicare or Medicaid because of the poor reimbursement.
I have to say, at the beginning, Lynn, one of the things we mentioned was the incredible flexibility in this bill. There's constant data collection and review for revision, for adding things. They can add and expand wherever it's needed. The one thing that is not allowed is that no benefits will be removed. So in terms of doctors, there are doctors on the board that makes the decision about payment, and there will be flexibility in the system for that. But as Ching Sim said, the bottom floor is Medicare, the absolute bottom, but they're planning on going beyond that.
Thanks a lot.
Are there any other questions?
Alice dropped a question in the chat saying, for the advisory board, users of long-term care were mentioned. Will there be any other types of patients in the group?
Yes, I think people that qualify now for Medicare in the disability community, for instance, are also included. So anybody else have another comment about that? Any other questions? If not, we shall move on. We will have room at the end of the meeting as well for some more questions. So we will move on for Tsukuru. Tsukuru? Oh, unmute.
Yes, I know. Hi. So there's a lot to say about this section, but I am covering program standards, Article 1, standard of care. So essentially, I was like struggling to how to summarize this section, but essentially what I can say about this is Calcare really proactively establishes structure and things like data collection to ensure health equity and eliminate disparity, and that's what's really wonderful about Calcare. So so Calcare shall establish a single standard of care or a standard of safe, therapeutic, and effective care for all residents of the state of California by a lot of different things. But anyway, I should summarize this. So okay, sorry, I'm just overwhelmed. Okay, so one of the things that they state is how it will establish it will make sure the healthcare professionals provide services in a culturally, linguistically, and structurally competent manner. So that really actually, affects a lot of, so when you talk about health disparities are not only caused by the financial, of course, like, as a lot of people mentioned here, it covers everyone in California. So, regardless of your income level, or if you are employed, by companies, it doesn't really, has nothing to do with your employment. But disparities actually are caused by things like language barriers or your sexual orientation, gender identity, where you live. Some areas do not have healthcare institutions. So so that covers, Calcare really covers a lot of that. So let's see. Yes, and also what I really like about Calcare in this bill, it states specifically participating provider has a duty to act in the exclusive interest of the patient. So I think Chen Sim or somebody else already talked about this, but the provider is not allowed to receive any kind of payment or compensation because, as the bill language states, they are required to act and provide services exclusively in the interest of the patient. So this is a really section that I like, healthcare equity. So the as I said, it works proactively to eliminate the disproportionate burden of disease and death by race, ethnicity, national origin, primary language of use, immigration status, age, disability, sex, including gender identity, and sexual orientation, geographic location, socioeconomic status, incarceration, housing status, and other population-based characteristics. I just wanted to raise one example before I run out of time. I'm probably like almost out of time, but if you know anything, I'm a member of LGBTQ plus community, and there's a lot of ignorance on the medical professionals part right now. And this is just one example, but a lot of lesbians, women who date women, they are actually denied sometimes, like pap smear. Actually, yeah, huge proportion of lesbian people have never had pap smear because doctors erroneously believe that the cervical cancer, you are not, if you're lesbian, i.e. like having sex with women, you're not susceptible. And you're susceptible only if you're having sex with men. Or trans masc people like myself, they are often denied for contraceptives because by definition, if your ID states you're male, it disqualifies you from getting contraception, which is wrong. But anyway, so Calcare, by educating doctors, like making sure that they're educated, eliminates things like that. So
thank you, Tsukuru. That was great. I wanted to throw in something in that section that I think is very important, and that is that AI cannot override a physician's judgment, which will help in reducing the feelings of burnout and depression that doctors are feeling right now that their profession has been hijacked away from them. There's also an Office of Health Equity that makes certain that these kinds of discriminations do not occur. So next we have Taishi.
Hi, everybody. I don't know why my video is sideways, so I'm just going to leave it off because it's kind of distracting. I was assigned the section on, well, you can see it anyway. The section on funding. It's Chapter 7, Sections 100670 through 100680, and there's basically 4 components. The first one is federal health programs. I'm just going to read it. The board is authorized to and shall seek all federal waivers and other federal approvals and arrangements and submit state plan amendments as necessary to operate Calcare consistent with this title. The board shall apply to the United States Secretary of Health and Human Services or other appropriate federal official for all waivers of requirements and make other arrangements under Medicare, any federally matched public health program, the Affordable Care Act, and any other federal programs or laws as appropriate that are necessary to enable all Calcare members to receive all benefits under Calcare through Calcare, to enable the state to implement this title, and to allow the state to receive and deposit all federal payments under those programs, including funds that may be provided in lieu of premium tax credits, cost-sharing subsidies, and small business tax credits in the state treasury to the credit of the Calcare Trust Fund. This section also addresses what some people have already mentioned, but under the purview of my sideways view of the board, and that is to enable Calcare to administer Medicare in California. Calcare should be a provider of supplemental insurance coverage and shall provide premium assistance for drug coverage under Medicare Part D for eligible members of Calcare. One big thing about this section is it addresses how Calcare will be increasing the income eligibility level, increase or eliminate the resource test for eligibility, simplify any procedural or documentation requirement for enrollment, and increase the benefits for any federally matched public health program for any program in order to reduce or eliminate an individual's insurance, cost sharing, or premium obligations, or increase in an individual's eligibility for federally financial support related to Medicare or the Affordable Care Act. So basically, to finish off this section, again, there's more elaboration on how Calcare will be administrating funding from the federal government for people that are eligible for benefits under Medicare, and again, that includes parts A, B, and D. Next section, Article 2, is the Calcare Trust Fund, and basically the Calcare Trust Fund is going to be the vehicle for which all of the funds for Calcare come to and are then administered. What's important about this section is that it makes it very clear that the board shall establish and maintain a prudent reserve in the fund to establish it to respond to costs, including those of an epidemic, pandemic, natural disaster, or other health emergency, or market shift adjustments related to patient volume. And also any interest accrued on funds that are still, reserve funds that are still in the trust fund will be retained in the fund and be used for purposes consistent with the fund. State monies that would otherwise be appropriated to any government agency, office, program, instrumentality, or institution that provides healthcare items or services for services and benefits covered under Calcare would be going into this fund. Moving on, I'm going to skip the budget. Budget's pretty straightforward, and it consists of the following components. I'm running out of time already. Operating budget, capital expenditures, special projects, budget programs, standards, activities, health professional education expenditures, healthcare workforce recruitment and retention, administrative costs, and preventative and public health activities. The final section, jumping ahead, is a special project budget. Some mentioned this is one of the most exciting parts of the bill. There's going to be a procedure for applying for capital investment in special projects. So this would be things like in communities that have already been underserved by healthcare facilities because private insurers determine they don't want to go there. And for all of the many hospitals that have been closed in the rural area, this fund will address those needs. And the final section is pretty simple. It's just the Calcare financing, where a revenue plan will be developed, and the Calcare program will basically work with the legislature to determine those plans. And the oversight on going back on the project thing, like in other parts of the bill, there's a lot of democracy built in. There's public hearing for it, room for public input and review on proposals. That's it. Thank you.
Thank you so much, Taiji. Really appreciate consolidating all of that. And our last, but of course not least, presenter is Jackie Hernandez. Jackie.
Hi, everybody. How's everyone doing? All right, so I had chapter 8, 9, and 10, which is transition, collective negotiations, and operative date. And this is where a lot of people have the question, right? How are we going to get into Calcare? Like, people think it's just from one day to another, but it's not. So the transitions occurs like this. It's going to be available for people who are 55 years and older, 18 years or younger, or are currently enrolled in Medicare or Medicaid during the implementation period. So this ensures that people can keep their current doctors and receive the same level of care. And insurance companies cannot limit or exclude coverage for people with disabilities, complex medical needs, or chronic conditions. Okay. And then the board is going to be working with advocacy organizations to ensure the best possible care for these groups. And the Calcare benefits will continue until discharge for patients receiving care in hospitals and care facilities. And then during that implementation period, the board is going to be in charge. The board in charge is going to be creating and manage processes to ensure people eligible for Calcare are automatically enrolled. So people who become eligible for Calcare after the implementation period will also be automatically enrolled. And this establishes procedures to help those eligible for Calcare, and they can choose their primary care provider and providers in their existing care team. So people don't have to, lose their doctor, as many people are concerned. And people are still going to be able to choose to maintain their current carburate outside of Calcare until the end of the implementation period. So there's going to be a process of time. And now the Calcare Trust Fund was going to provide funds for programs that aim to educate, recruit, and retain healthcare workers to meet healthcare workforce demands under Calcare. As everybody mentioned, some of the reinforcements on cultural competency and all of that, that's basically what's going to happen. We're going to ensure that everybody does have that education to do the work. So the board is going to be collaborating with various organizations and establish a Calcare Health workforce working group to provide input and recommendations related to healthcare workforce education and their recruitment and retention. And the board will also appoint members to the working group, aiming to have a broad representation, and each is going to be appointed member will serve at the discretion of the board, considering the input and recommendations from the working group and public comments in its deliberation and decision making. So now Chapter 9 is about collective negotiation by healthcare providers with Calcare. And a healthcare provider obviously refers to someone legally allowed to work in the healthcare profession in California. So they define that. And this person could be an independent contractor or someone who works for a healthcare group practice that accepts payments from Calcare. And a healthcare provider representative is a third party authorized by a healthcare provider to negotiate on their behalf with Calcare for better terms and conditions regarding their healthcare services. And this goes into the authorized collective negotiation, which is the healthcare providers are allowed to come together and talk to Calcare about the rates they are paid for healthcare services. They're not allowed to go on strike against Calcare as part of the negotiations, but it's important to note that any agreement reached cannot go against state or federal laws. And Article 3 talks about the same thing, collective negotiation requirements, and this means that healthcare providers can talk to each other about the terms and conditions they want to negotiate with Calcare. This also means that they can talk to representatives who negotiate on their behalf of all healthcare providers as a group. And once that representative negotiates the terms and conditions, all healthcare providers are bound by them. This does not limit the right of healthcare providers to petition a government entity for a change in law, rule, or regulation, but it does not limit the right to collectively negotiate with their employer or take any other lawful collective action. And lastly, Chapter 10 is the operative date, which is the law in California that won't be put into effect until the Secretary of California Health and Human Services confirms that there is enough money in the Calcare Trust to fund to pay for it. So the law adds that some of the new sections to the government code, which may limit public access to certain information, some information such as needs to remain private to protect people's privacy and businesses' propriety information.
Thank you
And that's
so
pretty
much,
much it.
Jackie. Appreciate it. I know that last little bit was about anyways, it's not stuff probably that deals with patients that much. So anyway, I'm sorry to move us along here, but the hour went quickly. So appreciate everybody. We do have a couple of minutes, just about 2 minutes for any questions. As we mentioned at the beginning of the hour, some of us are going to stay after from 8:30 to 9 if people have more questions, or if you just want to have a conversation about the bill, you're welcome to stay on until 9 o'clock, but the meeting will officially close at 8:30. So we have time for maybe a question or two. So any questions on Facebook? Scott? Or Dennis?
No,
Or Gina?
sorry, it takes me a minute to switch over, so
Sure.
no
No,
question.
Got a few hands up.
Okay, thank you. So we have 2 hands up, correct? James and Lynn. So James?
Well, the bill that you talked about, getting more healthcare into mainstream, about making it for the rural care of it, and it's about, getting it more to the ones that are needed most.
Yes, it is. And you know what? If you'd like to stay after 8:30, we can have a good long conversation about that because that's an important topic, very important point. So, Lynn, we have about 1 minute.
Real quick, thanks to Sakuru for bringing this population up. I had never considered that. What about prisoners in jails and prisons? I think some prisons are federal, so maybe the federal government takes care of them, but has anyone, is that anywhere in the bill that?
Yes, prisons are included. Prisoners are included in the Calcare system, every resident of the state. So
Great,
they
thank
are.
you.
So I think I'm going to hand it over now to Gina, who's got information for us about how we can help move this bill through the Assembly and the Senate and actually get some real health care.
Yes, folks, there's so many ways you can take action with us. And I dropped a link to that particular page on our website. We do fancy our website as the Google for single payer healthcare. So please use it. I often, when I'm looking for language on the bill or anything else, I always end up going back to our own website to find the answers to my own questions. So tomorrow, there is a Calcare training workshop that the nurses are giving. So if you didn't get enough Calcare tonight, join Calcare 101 tomorrow. The night after that, the teachers are actually sponsoring a webinar breaking down Calcare because I don't know if you know, but two of the biggest teachers unions have endorsed the Calcare bill, which is really exciting. California Federation of Teachers and the California Teachers Association. So UTLA best be next, right? So they're also hosting a webinar on, I guess it would be Wednesday night. If you haven't already, and I can't
It's
imagine
Thursday, this Thursday, Gina, the teacher.
I'm sorry,
Yeah,
Thursday,
it's all right.
If you haven't already, I can't imagine that you haven't. Sign the Calcare petition. That's on our Take Action page, which I dropped the link to. If there's anybody on this webinar tonight that hasn't signed it, I can't even imagine, but tell your friends, tell your family. Endorse Calcare, right? One of the things we're doing is we are canvassing businesses. I'm not going into businesses anymore without bringing a Calcare sheet with me and asking them, do they want to sponsor Calcare? So get your folks to endorse Calcare as a business. The other thing you can do is you can send the Assembly Health Committee a letter of support. We were looking for organization letters, but there is a spot there where you can submit a letter as an individual. You can even go on and put a comment on. So please go to our website and do that. Ultimately, harass your assembly person. Let your assembly person know. No vote for Calcare means no vote for them. Not ever. Not for this seat, not for any seat that they're going to run for in the future. Because let's face it, all of our assembly members right now are already running for other things. Dr. Akila Weber is running to be senator now. So here we are pressuring her as an assembly member, knowing that she's going to be a senator next time around. So please, 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 I just make it a weekly thing. Monday mornings, that's like I set my alarm, and every Monday morning I harass my legislators. It's what I do. It's Gina Viola again, just making sure you're still going to vote for Calcare. What's your position on Cal? Have you taken a position on Calcare? So you'll find that by the third time you call, at least they'll know what you're talking about. First few times they don't. There's events you can host a Calcare, meet and greet, something with a small amount of people. The nurses are more than happy to send you information to assist you in that. I mean, Osh himself even zoomed in to one of our Calcare house parties. So like, these are things that we can have happen. As a result of that, there's a class at USC that now wants a Calcare presentation, and they want Osh, and they want nurses, and they want us. So you never know who you're going to connect with by just talking up the Calcare. Anything else you want to add, Maureen?
Yes, for people that weren't on right at the beginning, I also want to let you know that, obviously tonight was just like a table of contents of the bill to encourage you all to read the bill, which is on our website. It is actually really nice to read. You don't have to be like an attorney to understand it. It's really written for the people, for us to understand it. I would also like to re-mention, because we mentioned at the beginning, that for a deep dive, if you want to have like serious conversations and tear the bill apart and really examine it inside and out. Our partners at Asian Pacific Islanders for Calcare, that's APIFOR, Calcare at gmail.com. They are hosting a reading and discussion group on a weekly basis, looking at the bill and really diving deeply into it. So to join that group, and Taiji, who is on this call, is one of the organizers of that, along with now I'm blanking, of course.
John Kawakami.
Thank you, John Kawakami. So anyway, so you can send the email to API4Calcare@gmail.com and put AB 2200 reading group in the subject line. So
May I say something real quickly?
Yes, very quickly, yes.
All right, if you do talk to your legislatures or email them, send them the link to this meeting, because we just went over the bill, and after that meeting with Ash Kalra, a lot of the legislatures don't even read the bill. So this would be an opportunity. I'm gonna put this up on our HC for Us webinar section, which you can find under resources, and you can get the link and send it to your representative.
Thank you, Paul. That is a great idea, a great way to finish the meeting. We're going to close. Thank you all for coming. Thank you, presenters. Yay, give yourselves a hand. Everybody did a great job. We will be closing the meeting, stopping the recording. But for those that want to stay on after, you can stay on if you just want to discuss, even amongst us presenters, if we want to ask each other questions, we can stay on until 9 o'clock. But the recording will stop and the meeting will end when we all unmute everybody and say good night to one another. And thanks all for being here. So everybody unmute that wants to
Thank
say
you,
goodbye.
everyone.
Thank you.
Goodbye.
Good night.
Good night.
Good night, everyone.
Good night. Good night.
Thank
Good
you. Good night.
Okay.